Cool. Welcome to the Strengthandchiro Podcast. This is season 2, episode 5. Is it, Stephen? Episode 5?
I think so.
We've got a lot to get to today. I'm excited to have a fantastic guest here, all the way from Puerto Rico. Excuse my pronunciation. I'm a Kiwi from New Zealand, other side of the world. Dr. Rafael Fonseca.
Yep.
Welcome to the podcast.
Thank you for having me.
How are you doing today?
We're doing fine. Going through a heat wave, surviving. We're here.
I should say, how are you doing this evening? Because 5 p.m. your time, well, 5:11 your time, 9:11 in the morning my time. So I've got my coffee, and you guys have your whiskey, no?
I wish. Water.
Yeah, all right, water. I think one time...
Officially.
Yeah, officially, it's water. We had someone on the podcast once, and he was throwing back the whiskeys. Hey, it was awesome. I wanted to join him, but it was too early for me. No, but hey, fantastic to have you on the podcast. As always, me and Stephen are excited to kind of hear a little bit more about you. What makes you tick? What gets you up in the morning? You know, why chiropractic? Why all that good stuff? But before we get into that, I should introduce Stephen to his own show. You know him as Dr. Stephen Redman. I call him Redmon, or the Tony Stark of chiropractic. Welcome to your own podcast, Dr. Stephen Redman.
Thank you.
I wish I had an intro like that. He definitely is. He definitely is Tony Stark, and I love to Photoshop his face into images of Tony Stark, which you might see pop up on social media or on iTunes, you know, from time to time.
I definitely show up in my DMs pretty regularly.
Can we get an update on the dog, Dr. Stephen? I need a dog cam.
Yes, he is right over here. Right over there.
Hi.
You know, the dog gets, like, when the podcast is really good, the dog gets excited. You see him start pacing in the background. Or maybe he's just telling you to hurry up and finish up.
Yeah, it's probably the second.
Because it starts light, and then slowly as the podcast progresses, it gets darker behind you.
Well, thankfully, it's now summer, so it doesn't get dark until like 9 o'clock at night.
True.
So
Hey, lucky.
4 hours of daylight.
So you've got like you're in like a good climate, right? You've got like a good heat. I'm in like it's cold where I am. And Rafael, you're just like in a heat wave. Is that right?
I wouldn't say I'm having good heat. It's like 80 some degrees outside, but the heat index is mid 90s. So it's about a 10-degree increase right now. As it gets a little bit deeper into summer, it'll jump up. It's about a 15-degree heat index differential.
Yeah, it's the same here, kind of the same heat index. But right now the heat wave is because we get something called Sahara desert dust.
Yeah.
So if you see like the whole island, it's like covered in dust right now.
Whoa.
So it's stifling, and we get like it's dusty outside, obviously. And yeah, it's just the humidity doesn't help. I think the humidity was like 75% today. So
yeah, we get a lot of humidity. You know, it's like a dry. Like sometimes you get, if you have like a dry summer's day, like a dry heat, and you can be under shade and you have like a breeze, and it's just beautiful, right? You go down to the beach, it's just lovely. Other times, if it's really humid, like nowhere's safe. You know, unless you're inside with aircon, nowhere's safe. It's just not good.
So yeah, the whole mixture of things right here, right now, it's just awful.
Yeah, I can imagine. So being so hot, like, do you have patients coming in that are just like real sweaty?
Yeah,
I do all the time.
especially. I mean, I live in here. I practice in Texas, so I got construction workers that would like work the whole day on the sun and then come in at 7, all dusty, like full of sweat, and you just got to do it.
And you're like doing side postures, giving them a good hug as you side posture them.
I mean, I was in a hospital setting, so masks help a lot.
Yep. What about gloves? Do you wear gloves?
If I was doing dry needling or something like that, I would.
Yep.
But other than that, I wouldn't.
Yeah, like you see some chiropractors and they're doing like adjusting like a cervical, and it's like they're a neurosurgeon. They got their black gloves on. They got like the music in the background.
If I see them and they're like really dirty or something, I will put on some gloves. Yeah.
If I ever come see you and you start putting on the clink, start putting on the gloves, I'll be like, man, I need a shower.
I would like decide on visit 1. If I'm performing the exam, if I do it once, I got to do it every visit. So they don't know that it's then. So like if I use it once, I would try to put them on as much as I can.
I suppose that's nice for the patient so they don't feel stink.
Yeah, I mean, some people know it. Like, yeah, hey, I'm a construction worker. I come in, like, I know I just came from work.
Mm.
But some people are like, I don't care. That's you're just doing dumb.
They're just doing
Sometimes I
their
wish I wore gloves, like when I'm doing some of the manual therapy stuff, especially like when I use a topical cream. Because I
Mm.
hate leaving the patient in the room. I'm like, all right, I'm gonna go step out and wash my hands. Sometimes I have to do it 2 or 3 times during the visit.
Those creams and stuff. I'm scared I'm going to rub my eye.
That's why I'm so afraid that I'm gonna
Yeah.
wipe it on my face or in my eye, and I can't smell. So I'm like, I don't even know if it's on me.
Okay, let's get on with the podcast. So, hey, first things first. Have an impressive resume, if I can say. Studied biology, masters in biotechnology, and then we went to Life University. Between that, you were working in Big Pharma for 3 years. Do you want to give us a little bit of a rundown? Who you are, where you're from, what you've done, and kind of why you're doing what you're doing? What gets you up in the morning? Why chiropractic?
You said Dr. Fonseca. I'm born and raised in Puerto Rico. Went to school for biology here. Did my master's in biotechnology. Worked in biotech, biopharma for a few years at a company called Amgen. And just decided it wasn't for me. Long nights, working labs on like 12-hour shifts, doing the same thing. Wasn't really my thing. It got boring pretty quickly. I wanted to do something where I could kind of use my head a little bit more.
Hmm.
Instead, because when you're working in manufacturing, everything's like a recipe. Everything's done like step one, do this. Step two, do this. This happens, do this. This happens, do that. So like, as long as you know the equipment, I can give you the SOP and you can go to work for me. If you just, hey, you know the equipment, you know what it is, and you can just go through the steps. So it gets boring. Like that's how I felt. A couple friends were studying chiropractic at life. I went to a chiropractor most of my college life, college career, I guess. I did a little bit of judo in college, so injured my shoulder a bunch of times. Chiropractor really, really helped. I was talking to one of my friends that was in life, and he's like, hey, if you don't like what you're doing, do something different, obviously. But he told me like, hey, why don't you come here and study chiropractic? Took me like another 6 months, and literally mid shift at like 3 a.m, I'm like in my computer putting data on, and I'm like, you know what? Let me open up this application and just start it.
Wow.
So yeah, did everything on company time.
What was the most challenging part of getting yourself from that job, that situation, and actually getting into chiropractic school? What was kind of the most challenging part of that process?
I was very hesitant. I was born in this island. Like obviously I've traveled, but never had lived outside of here. It was basically another country, different language, although I believe my English is pretty good. It was a big change. And that was a big factor of why I chose life. It was obviously I knew a couple people, but it also has a big Puerto Rican community. Other than like at the time, I didn't know what evidence-based practices were. I knew I wanted to practice science-based at the time, but
ethically,
ethically, yeah, because that's my background. So yeah, I decided to go to life because 15% of the student base is Puerto Rican. So at time, like Steven could tell you, like you would go to a class and it's like 2-3 rows of just straight Puerto Ricans.
That first day of class, you walk in and you see all these Puerto Rican people. I was not expecting that.
Pretty cool though that you had that community.
Yeah, it's the diversity at that school is unparalleled.
Yeah, knock life for whatever you want, but the diversity is something you cannot knock them on. They do a really good job on that.
So you were talking about you were playing some sport, you were doing some stuff, you had some issues. How did the chiropractor or the chiropractors or chiropractic in general, how did that really help you with your injuries or your struggles back then?
So I went to a doctor, like just my primary doctor, gave me a couple meds. Like, hey, I felt fine. Went back to practicing and like competing in judo. Shoulder got messed up again. I'm like, okay, doctor didn't work. What I actually liked about my chiropractor that actually like opened me up to the profession was like at the time I was a junior. I was taking a biochem class, and my chiropractor would go like, "Hey," and just started quizzing me on biochem, and I'm like, "Hey, okay, that guy's pretty smart." We just made a connection with that, and but he actually helped. He was the first person that told me like, "Your rotator cuff is messed up. Let's start doing some exercises." And he didn't do them in the office. Like he was an activator doctor, or he is an activator doctor. But he actually put that idea on me, like, dude, just do these exercises, try to do this, modify this. So I'm like, hey, no, like nobody sat with me before and just went like, you're doing this, try to do that, try to modify my lifestyle, try to modify my exercises. So that really put me in, it's like, hey, that chiropractor really helped me out, allow me to compete for an extra year. So it really helped me. And that kind of stuck with me. It's like no other type of doctor sat with me and just went step by step, baby steps. Let's do this, act this way, and like progress through the whole thing. And yeah, to this day, my shoulder is a lot better since that time.
Yeah, that's a cool, it's a cool story because it's real easy to lump certain styles of chiropractic, especially for someone like myself that, I'm real big on evidence practice and scientific method and things like that. And when I started doing the activator paper in chiro school, I was like, this is a load of baloney, like I was just like, I couldn't handle it. Like I couldn't stay in the class. I was like, this is just ridiculous. But what I loved about what you said was all those protocols, right? Finding provocative movements, modifying what you're doing, adding in exercise-based rehabilitation, which is where the science and where the research shows is most effective. All these things any doctor can do. It's like you can have a toolbox that helps modulate pain, or you can follow the activator method to the letter. But if you're a doctor that has all those other aspects in your practice, you're definitely going to help people. So that's like a cool story to hear because, sometimes it's easy to judge people, on the style.
On their technique or their style, yeah.
When there are definitely Gonstead doctors that are killing it, doing good work. There are definitely I mean, I haven't heard many activators. That's why I'm saying it's cool to hear that. But yeah, activator people doing good work. There are all these people that are doing good work. It's just easy to lump people in sometimes.
Give us a rundown on what the profession looks like in Puerto Rico.
It's not like, if I can just sum it up in a few words, it's not evidence-based. For the longest time, like most of the doctors here went to life and went to like the old school life. Steven and I kind of got like the life experience, but like the diet version. These guys were like full on like adjust, or like if you don't get adjusted, you die. Like that type of thing. That's what people know here as chiropractic. Like adjust me, like my hip is out, my bone is out. It is, like I said at the beginning, it can be very frustrating. Just to like constantly hear what people like, yeah, my old chiropractor like told me my C3 was out to the left, and like that's messing up my shoulder and my elbow. And I'm like, I think you have a rotator cuff tear, not anything but your neck, just to bring it back to my shoulder. But there is like hope. I don't know if you guys, I know Steven knows, but a new school opened up here in Puerto Rico where students begin their classes with, it's inside a med school. So they like first year is with medical students, and then they kind of branch out into the chiropractic part. So like they are getting like a very evidence based school here, so that there's hope.
Mm.
So, but a lot of changes need to be made, a lot of push, and hopefully we can get it done.
You're definitely really positive about it, and that's really cool to hear, because obviously it's so easy just to sit there and shit on the profession or whatever, but you're just like underlining everything you're saying is like, you know what, things are getting better, you know what, this profession is worth it, you know, like things are progressing. It's just, you can see how it can be so frustrating for other people in the medical industry watching, you know, where you have got very traditional chiropractors doing what they're doing. And a lot of people say like, well, it's not my problem and it's not my job to police them and it's not my job to challenge them. And, you know, me and Stephen, like we love to have this podcast to mostly highlight the good, you know, not really focus on the negative, but occasionally we do like to talk about and address the negative, because I feel like it's important to at least talk about it. I'm definitely not someone that's going to like go around and attack anybody. I mean, it can be vicious on the internet, and that's definitely not helpful. But talking about it's important.
Yeah, something I learned in life, like the school, not my life, but something I learned at school is like, if you have like a tight group of like people you need to bitch with and like just vents, it does help a lot. Like that's where things kind of like the little groups Stephen and I had at school,
cool.
Facebook groups like the FTCA and stuff like that do help a lot.
Yep.
And that's kind of like what I'm trying to do here in Puerto Rico, just link up with as many evidence-based doctors as I can and see what we could do. Like, okay, if we need to like just all join the chiropractic association here and just make some noise there, just start pulling people together, because if nobody does anything, things are not going to change, and things are just going to stay the way they are. So it's just it's just about that. It's just pulling people together, having a small community, like.
And almost every time we have people from all around the world. One time we had 4 separate time zones on this podcast. Every single person in every single time zone was pretty much talking and explaining the same problem with healthcare, pretty much. And that's a really interesting thing, because obviously there is a niche for, you know, high quality evidence-based conservative care that can help people, that's not going to be, you know, cutting them open or prescribing them drugs. And that's the importance of what we are doing in all facets of conservative care, whether it's a massage therapist or you're a chiropractor or you're a physiotherapist or you're an osteo, whether in your country you're an allied healthcare professional or you're a primary healthcare professional, because it differs, it changes from country to country and jurisdiction. The most main thing that I found I struggled with in college was I quite actually liked the philosophy of chiropractic. You know, like D.D. Palmer, and, you know, the dude's back was out, and was it Harvey Lillard? He had something wrong with his back and whacked him on the back and he got better, you know, and then like with, you know, BJ, and then the hole-in-one method, and then obviously Gonstead. And I actually quite enjoyed learning about the history. I enjoyed, you know, the whole hypothesis of neural interference. I actually quite enjoyed all that. I was like, oh, this is actually quite neat. I can see why people buy into this. It's quite a neat hypothesis. It's quite, when I say neat, I don't mean like, oh, it's cool. I mean like it's quite a tidy little hypothesis that you can easily buy into. You know, pressure on a nerve, corresponding nerve causes symptoms. You know, restore nerve flow, people get better. I was like, at first, I was like, this is fantastic. How, you know, why do medical doctors don't know about this? How come, you know, how do physios don't know about this? How do, you know, it blew my mind. And slowly but surely, you realize there's some major holes in the philosophy. But I think the philosophy itself is great. People should continue to teach it. The problem with us is that we had our science classes, we had one biomechanics class, which was piss poor, but you know, we had our classes that were set in evidence base. And then we would have our philosophy classes. And then all of our practicum, hands-on technique classes, they were all philosophy based. And what I mean by that is like they were all based on the belief system behind chiropractic rather than reality, right? And so that was the only thing I had a problem with, because I'd come from philosophy class and I would challenge the philosophy to my teachers and technique, and they would just bash me down and be like, no, we're restoring nerve flow. Then I'd go to my science classes and they would be like, no, that's not really what's happening. And whatever. Like, and it's interesting, like even within the departments, even within the school, people had different opinions. It was almost like we got a really good like the science classes at my college, fantastic. I'll never say anything bad about the actual core, the basic science classes, all that stuff. Really good, great teachers. We had PhD professors and all that kind of stuff. But we would sometimes ask them questions just to like rub them up the wrong way. We'd be like, so what is a subluxation? They'll be like, well, it's a partial, it's a luxation, less than a luxation. And they'll give you the medical determination, well, that's not but miss, that's not what we're learning in this class, and this class, and this class, and this, and so you kind of see what I'm saying, right? How do you overcome that kind of preconceived notion of what chiropractic is when in Puerto Rico you're saying everyone kind of just knows it for that philosophical model?
Or like the way I like kind of internalize it, it's like all that is like it's our history. So we kind of need to know our history to not repeat those mistakes. And between chiropractors, we can talk all we want about philosophy and like whatever, but like it's always going to go wrong in my mind if the philosophy is leading your clinical rationale. If that's why you're doing stuff, then you're doing it for the wrong reasons. So like I basically like, hey, I went to life like that's philosophy is board material. If you ask me, I know it. It's in my head, but I don't let it like take over why I do things. It's like, hey, I might use like a little bit of like to explain it to a patient. Because sometimes like, hey, that's what they know. And I might slowly bring them up to like an evidence-based method. But I got to meet the patient where he's at.
Absolutely.
Where he's at. So and like if I go like if they come in, like I said earlier, my C3's out to the left, and my old doctor used to like ring ding me and like whatever. Sorry, can I say that? No, that's trademark.
You can say it.
I don't think ring ding ding is trademarked.
So like if the patient comes in and it's like, yeah, he used to like yank my neck and like whatever, and that fix it. I'll take my time and like, okay, yeah, we'll do something similar, and I'll slowly put in it's like, hey, what we actually doing is like actually moving those joints, putting motion into those restrictions, and slowly working through them. Like I can't go in and it's like, no, your last doctor was completely wrong, and like because that's too jarring. Like the patient's gonna be like, this chiropractor doesn't know what he's speaking, or like he doesn't know, he's not a real chiropractor.
Yeah, and then you might lose the patient, and then you won't have the opportunity to help them.
Exactly.
Yeah.
So like we gotta start, like we gotta use those things that we kind of know, slowly bring them up to where we're at. I cover a lot of offices here, like that's what I'm doing a lot. So I kind of have to go with the philosophy of stuff of the office I'm covering, because I can't leave them with 1,000 questions of the things I said, and the other doctor is going to tell them like, no, it's not. It's all in the philosophy and like it's serving nerve flow and all that. But then I'm going to look like that patient's going to think of me and like he was just talking BS. He didn't know what he was saying. Because my chiropractor said he was wrong, and that affects my business and whatever. Because like I'm messed. So like sometimes I do got to play along and just, hey, it's the nature of the job. But my patients, I kind of go like meet them where they're at, slowly bring them up. And at one point they're like, hey, so like this guy, at one point they're going to be like, I heard this on Instagram and like they were saying that's a lot of BS, right? And that just warms my heart. That makes my day. When they start calling other chiropractors BS because it's stuff I taught them, that makes my day.
Yeah.
They send it to me on Instagram like, I think that's a lot of BS. And I'm like, yep, I did my job.
Yeah. I really like that approach. It's like it's quite a refreshing approach, because we know that like doing nothing is probably not the answer, but then we also know that just throwing new information down their throat is not the answer either, because like you said, they're accustomed to what they know. And again, the system and the philosophical kind of ideology around nerve flow, it is really, like, bone on a nerve is really easy to get, and it's really, that's why I think that's why we gravitate towards it so much. And it's really easy to pick up a spine, show them at a glance how things could be happening, where things could be happening, and I feel like people really resonate with that. So then to be like, that's not out of place at all, and that's just a perception of your brain and where you are in space, and really we're probably going to need to do more than just crack your back to start to approach the situation properly or long term. The other thing I find, people also, if you give them a progression, like, a lot of people don't actually want that. Like, a lot of people just want, like, wham bam, thank you, man, like, crack me from head to toe, flying 7, make me feel good for 7 days, maybe I'll come back in a few weeks. And when you lay out a plan, it can either be too daunting, they can either not understand it, and unfortunately, sometimes people just don't want to do the work. And we talked about that a little bit on the last podcast, with a guy called Rob Cox, who's an osteo student from London, but he's like a sports rehab therapist. He's a bodybuilder, and that was something that he was talking about. And I was sitting there thinking to myself, I've experienced that a lot, but it's always refreshing to talk to people. Obviously, I hear Stephen's opinion on it all the time, and it's always refreshing to talk to people that have kind of not different perspectives, but different ways of dealing with things. And I know Stephen will often talk about, not to put words in your mouth, but I like the way you do this, Stephen. Is like, like similar to what you're saying, meet them where they're at and give them what you think that is attainable for them at that time. So it's not the whole pie. It might be a piece of the pie, but sometimes it might be the whole pie. If they want it, if they need it, it's just like, it's case to case. So based on you, with your experience since you've graduated, how important is communication between you and your patient when it comes to actually having positive clinical outcomes?
Super important. So when I graduated, I sucked at communicating. I have no issue saying that. I sucked. I jumped into a practice in Texas, and it was like, I went from seeing 10 patients in my 10 patients a day on my internship to 30 12-hour shifts, 30 something patients, half-hour visits, full with rehab. And half the time I was like, whatever. I stuttered a lot. Hey, I still stuttered, but you kind of learn what works. And what I failed a bunch. I lost a bunch of patients, and then I kind of took a step back. And I'm like, okay, what am I doing wrong? What do I have to what do I have to fix? Because I was doing the opposite of what I told you. I would just go full on evidence based, no philosophy, nothing, and I would get blank stares.
Yeah.
If I just go full on evidence on this 60-year-old lady whose hip hurts, I lost her. I saw it mid evaluation. She's like, I can't connect with this person because I just went above her head. So yeah, I took a step back and I kind of slowly okay, I gotta ease off. I gotta bend a little bit and start playing where they're at. And obviously I talked to a bunch of people. I was really, really fortunate to work in a company who could get me coaches. A lot of other employees, I would just hey, ex-doctor in the company near me in Texas, and we just go get a drink after we go out. Let's just talk about this. And I would ask them, ex-patient, what do you get? What do you say? Because I don't have the words. And piece together is people I'm just gonna put some names out there, the Keela Browns in Arlington, Texas, Dr. Bo Crochet, with I think Stephen knows, in Dallas. Those people really, really, really helped me. But it took time for me get all that information from them and the coaches from the company just to start implementing everything.
Yep.
And then like I started seeing, hey, I kind of, and then everything just clicked once. Like one day, everything clicked, started rolling with it, and then just kept going. And you never stop tinkering. Like you always change, and you even change. Like, man, if this podcast was in Spanish, I would sound like a completely different person. So like if my patient speaks English or Spanish, like they some days you will feel like this is a completely different doctor visit from like the English speaking patient to a Spanish speaking patient.
Yeah.
There's research on it. Like you speak in different languages and you kind of become a different person. I digress. It does take you, and even with Spanish speaking patients, it's totally different. Like they with my experience, Spanish speaking patients got like do things to me. They don't want to do work. They don't. My English, like my American patients over there in Texas, they were easier to convince to like do exercises. My Spanish speaking patients, I would like. They love manual therapy. Like they like if I do stuff to them, oof, they're hooked. If I tell them to like, you got to do this exercise with a band, like X amount of days, X amount of times in a day, and like a couple of reps, slow, like stretching your car, do this before you go to work, stuff like that, lost them.
Wow.
So like it, and that goes to the same, like meet the patient where that and that kind of goes like different cultures have different things they kind of like, different things you kind of have to say to them. So it does take time, especially like if you're working in a city where you see a lot of like diversity.
Yeah.
Like I said, I was in a hospital, so I kind of saw a lot of different things. In a Fort Worth, Dallas area, so a lot of diversity in the area. You kind of start getting an idea of like, what am I going to do with this type of patient? What am I going to do if they speak English? Okay, I kind of know I can introduce rehab the first day. Mexican patient that I'm like, I need to like do a couple sessions and then slowly kind of hide the rehab into it and then slowly work them up.
Fantastic opinion and thought process kind of around what you kind of encompassed there was communication and cultural competency, right? Which is really cool to hear. Yeah. Really, really cool to hear. What advice or feedback or direction would you give to a new grad if they don't have that support network where they feel like they can reach out in the workplace or they can have people to help them with their communication or even cultural competency awareness? What would your advice be to those people and to get better?
I mean, it never hurts to ask even the patient. It's like ask them their preferences, and you kind of start getting the hang of it with that. Obviously, like just read up on it, see what other doctors do. Kind of like it does. Just because you're not working for a big company doesn't mean you can reach out to other doctors. Even on like, just look up there's your chiropractors nearby. Maybe you'll find somebody that will sit down with you. That's what I would do. I would start reaching out to other people. If you find like that niche of like a community, and just read on their culture, like know their food, like know what they speak, like just put some effort. Like that's the thing.
Yeah, of course.
It's not like you need to do like you don't need to learn like their whole culture, but if you can talk to a patient and just have something you can relate and ask what their preferences are, like obviously like Muslim patients, they come in with a hijab. Don't go and it's like, hey, can we take this off? Obviously, just find a way. Like, if you want to work on do some manual therapy on the neck, hey, do it over the hijab. Ask them. But communicate with the patient. You're never going to hurt the patient if you ask them if it's okay to do that. Sometimes you're going to say they're going to tell you no. Just figure it out. You don't have to do everything the same day. Just slowly, if you get them to trust you, then you can do whatever you want.
Yeah. It's also like being able to identify or just being aware of also like certain things that it's easy to connect with people on that kind of will often cross cultures. And what I mean by that is sport crosses culture,
Mm-hmm.
right? Um, big no-nos, religion, politics,
Mm-hmm.
veganism, keto. Nah. I interrupt this podcast to thank Raisies for sponsoring the Strengthandchiro Podcast. Raisies is a family-owned New Zealand business that only produces high-quality, all-natural and clean products. If you're anything like me and you need a protein that tastes good, mixes well and contains no additives or nasty preservatives, this is for you. This protein is New Zealand-made, ultra-filtered, gluten and GMO-free with no artificial flavors or colorings. If you are an athlete or you love to train hard, it is essential that you get an adequate amount of protein. We would like to thank Raisies once again for sponsoring the podcast. You can get 10% off at raisies.co.nz. Yeah, but you know what I mean? Like people, if someone's a CrossFitter, regardless of their culture, I'm gonna take a punt that they're pretty passionate about it. So yeah, like there are certain things. I've definitely like if someone else is a dad, like I can like really like tune into that frequency, you know, of another dude being a dad and like really like talk about family and they love it. Like there are things for those out there that like get nervous around the cultural competency thing, because I know when you're learning about it in theory at university, it seems it's quite a daunting thing for a lot of people, you know. And
Yeah, you can kind of drown yourself in it, and it's like, and
absolutely,
you can. There's a saying in Spanish, you're drowning yourself in a cup of water. But yeah, it's you just got to start somewhere.
yeah,
The
absolutely.
hardest step is the first one.
Yeah. And obviously, like you're saying, being able to reach out and find people now, like we have the benefit of social media, and there are these like social media communities and pockets all around the world that you can tap into and ask for help. And usually someone that is really passionate about what they're doing, they're usually very, very happy to help or happy to answer a few questions. In the past, I have messaged people, you know, and ask questions, people that are very, very well established in the industry. And I've, you know, many, many times, more often than not, I've had positive response of wanting to help. People that are really passionate about it do tend to really love to talk about what they do, you know? So it's just about asking the right question. I'm interested, Stephen, like what your journey has been like with that in your own words, graduating and navigating patient communication and then also cultural competency.
So I have kind of a leg up, but then it's also a detrimental leg up as well. Since I started out as a massage therapist first, I
Yeah.
was used to having an hour of time with the patient, and it allowed a lot of time to build trust. It allowed a lot of time to make those connections that weren't apparent
Yeah.
doing a quick history and figuring out what's going on with them. And so it allowed a lot more time for those subtle things. Like I know to this day that since I don't do hour-long appointments with all my patients anymore, there's stuff that I'm missing. I just don't know about in their life, things that are affecting them, that are contributing or positively or negatively to what they're experiencing and why they may or may not be getting better. And that does kind of bother me sometimes when I think about it. So try not to think about it. Like I knew my patients way better when I was giving everyone an hour massage than I do when I
Yes.
see them for 15 minutes, 30 minutes, 45 minutes. It's just the way it is. There's more time for those connections. So
Mm.
I struggled at first making sure I got all the right questions in and was starting to piece together who this patient was or who this person was in front of me. And I got better with it. The nice thing about jumping into that high volume place part time right out of school is I was forced to do it in 5 minutes or less. So
Yeah.
I went from not being able to do it in that quick a time to becoming very, very efficient with communication and making those connections and recognizing different cultures and what I need to do with different people So yeah, it to some degree, especially like in school. In school itself, it was great because everything goes slow. You just hurry up and wait. Like in clinic, it's just like get it done, and then you wait 30 minutes for the clinic instructor to come on over and do the thing. So yeah, you're just sitting there talking with your patient, getting to know them. Like, it's easy. But then in the real world, it's not like that. It's you're not waiting for someone to sign something. You're not waiting for someone to look over and oversee your treatment. No, you're doing everything as you do it. So it was a very unique experience for me. And I would say I've grown tremendously. I struggled a bunch, but I've grown tremendously. Favor a slightly longer appointment because I do know from history that I'm missing information. So if I can spend an extra 10, 20 minutes with the patient,
Yeah.
I tend to like that, even though it does cost them extra money and they may or may not need it. So I do have to explain those things.
And obviously, naturally leading on from that question is talking about average treatment
Mhm.
time. So for you, Dr. Raphael, what was your average treatment time be with a patient?
Back in Texas, it was half an hour. I did everything from 15 minutes to an hour treatment. My initial visits were around 45. If I had the time, I'll take the hour. Average out 45. When I transitioned and like moved to Puerto Rico, stuff changed. It's a little bit more high volume here. Insurance don't pay as well. They don't cover, like, it's not like I could do 45, 2 units of rehab with the patient here. First, because most offices don't have that amount of the equipment, or like, I'm not going to do half an hour of like exercises with bands with the patient. So I kind of had to like shorten everything and condense it.
Yeah.
I average out here like 15, maybe 10 minutes sometimes. It depends on the office. I I just switch around depending on the office, really. I do have like a little space in a gym where I can kind of take my time, and there I average out like half an hour.
Yeah.
Yeah. If I'm working on someone, basically, if I'm working for me, I'll take half an hour. If I'm working in an office or covering, it's usually 10 minutes or less. I've covered offices where treatments are done in like 5 minutes, like actual contact with the doctor patient is like less than 5 minutes. So very high volume. And that's just, but I mean, I cannot, it's their business.
Yeah.
They kind of like, that's when they decided like they're just going to see 100 patients a day for 5 minutes, and just cycle through them. And I just go in and help out, kind of fill their shoes for a while. But if I, like, ideally, half an hour.
Yeah. I mean, imagine 5 to 10 minutes being very short. I've told this story lots of times, but we had a person come talk to us, and they were telling us a story about how they were trying to get their patient times down. And what they would do is they would quite often hand out surveys, and they would ask their patients how long they thought they were being treated for, so that they had a pretty good idea of the perception, of what the patient, how they were feeling. It is a important factor, right? What the perception of your patient, because like you could be seeing them for 5 minutes, but they could feel like 15. He got his patient times down to 2 minutes, and they felt like, from memory, I think they felt like it was 10 to 15. They were seeing him from 10 to 15. And yeah, so like that is an extreme example. And in that situation, he was very strict on the services he was providing. It was only check and adjust. That's it. Nothing else, right? He would just refer everything else out. So he would have soft tissue, massage, physios, rehab, all that. He had business cards, and he would just business card, refer out. And then similarly, those other businesses would refer to him just for adjustments. And so he kind of had that, he cranked into that niche and built $1 million practice from doing that. I find it, like, personally, I find it unethical when treatments are too short. I mean, I understand there's situations where, like, if you're going into a place, of course, you're not going to start throwing your weight around and be like, no, I'm doing half an hour. Like, of course, I understand that. But I mean, like, if you had your own practice, if you had your own rules, like you said, 30 minutes would probably be quite good, a sweet spot, right? I am interested to learn a little more about your interventions, or, you know, what you use with your patients, because I know you have a few extra certifications. And I've done a dry needling diploma myself. Not that I use it, but I don't have a problem with it. I think dry needling is a fantastic tool, really good. One thing I'm interested in, though, is the Graston cert, because I've heard I've heard a lot of good things. Like, I've got a bunch of tools here, IASTM type stuff. Like, I've played around with it. I've done some, like, base level certifications. I've got some tools here, but I'm interested in Graston specifically because I've just heard a lot of negativity around the certification itself, not around what it does. I'm not talking about clinical outcomes. I'm just saying in terms of like renewing it, or in terms of like who can get into the program. And I've just heard that it's like a little bit problematic.
I mean, I think a couple years ago, I think when I started taking it, they had opened up the course to a lot of more professionals. I remember I took the first course with an occupational therapist. So that was cool to see. Everybody else was a chiro student or a chiro at the time.
Yeah.
But seeing, and I think I saw it in their website that I think they opened it up to a lot of more people. The information on it is quite helpful. Money-wise, if it's worth it to you, it's okay.
Do you recertify? Do you have to recertify every certain month?
Every 2 years.
People want to pick up extra skills, especially one thing me and Stephen talk about is what certs can people do to pick up and to increase their hands-on ability and skill. And we often hear, when I ask people about it, we often get like ART. I haven't actually spoken to anyone like personally that's done Graston, so that's why I'm interested in your experience.
And like we talked at the beginning, it's like you don't have to do like straight Graston and just use the blades. Hey, you need no ART and you do Graston, combine it, see, hey, even if the patient doesn't like to be touched with hands, see if they like tools, kind of do the ART with the tool. Maybe the patient doesn't like the tools and you kind of go more ART. It's, again, kind of bringing it back to like meet the patient what they like and the preference.
So is ART,
yeah,
do you get taught that within the Graston program?
Not really.
No, so you're just saying, do you have an ART?
Like,
in general, I see what you're saying.
I don't have an ART.
Yeah.
I've read the books.
Yeah, pin and stretch and stuff like that.
Yeah, pin and stretch.
Yeah.
Not really that complicated.
Yeah.
But I actually, my computer's sitting on the ART manuals.
Nice. Yeah, so you understand the protocol.
Yeah, I understand the protocol, so I can kind of pull a little bit into it. The company I used to work with in Texas, they do a lot of myofascial release.
Yeah.
And I kind of like introduced that with the Graston. I can use my elbow, and the patient liked it. If they didn't like the using my elbow, too much pressure or whatever, I'll grab a Graston tool and kind of do the same thing. You apply the pressure with the tool.
Yeah.
So you just gotta adapt.
Cupping?
I do.
Yeah, cool. Yeah, I really I quite enjoy cupping. Like, even just from a personal perspective, like I will, like when I get migraines and stuff, I'll get my wife just to like light up some cups on the back, like traps up into the, like up to the neck. And like I personally actually quite enjoy the feeling, like the feeling of it. And then, for whatever reason, and for whatever reason, it makes it actually helps, especially when like my wife doesn't have the hand strength to massage, like she can't massage me, like and that's like, it's not unusual. I'm quite a big guy, like I'm a powerlifter. I've put my body through hell. I've got very like tense, tight, big muscles, but so it's really hard for her, like, you know, so often like she will do like some feathering or scraping with the tool, or she'll have, you know, if like when I'm in pain, she has to kind of reach for certain tools because she won't have the hand strength. She can't adjust, obviously. She's not like a therapist or anything. But like obviously with me, I've got super strong hands, and so like I trust my hands a lot more. Like, and one thing I love to do, I just my at the core of my practice is movement, and what we call at the CFMC, which is a group of us all over the world. If you can get somebody to kind of internalize the stimulus, add an aspect of active movement to a pin and stretch or to whatever you're doing, even like we had Dr. Marv on the last podcast, and he was saying that he does PNFs to all his, when he adjusts, he PNFs all his patients. Like that was real cool and interesting to hear. Like he gets like a massive kick, and his patients just love it to the point where.
So yeah, I do myofascial release on all my patients.
Rafa was doing one of his Raston things during COVID, and he asked me to come over and be his partner. And I was like, yeah, that's great. I'd love to, because I already understand movement. So I'm not going to be trying to learn everything while he's doing it, because I know some of it, but I will learn some things. But I was like, just a heads up, my left shoulder doesn't really move right. Like if we're doing stuff on the shoulder, it's going to be a bit funky. And then I showed him like I can't like really bring this shoulder up. I have to like pick my whole shoulder up. I can't isolate my levator scapula on this left side. Like it just doesn't move. This right side, up and down, up and down. This right side just does not move. I'm squeezing and squeezing. There's nothing happening. And so I'm on the table and they're like, we're going to do some stuff on the shoulder. I'm like, oh my God. So they're like,
screwed.
Rafael, it looks like your partner, they're not moving, their shoulder's not moving. Do y'all need help over there? And we're like, no.
Like, I'm trying.
Come on, Stephen. Hey.
You didn't tell them that I bought you a Chick-fil-A.
Yeah, that too. Yeah, I got some Chick-fil-A out of it. It wasn't completely pro bono.
It wasn't like, just come to my house and then you'll take the course with me. I need a patient. It's like, no, I'll buy you some Chick-fil-A. Come to my house and we'll do this Raston course.
It's worth it for Chick-fil-A. That's the one thing I wish we had in New Zealand is Chick-fil-A. Like seriously, I loved it when I was in America. I was throwing it back.
I have a stepbrother who's half Panamanian, and he grew up half his life in Panama. And he'd never had Chick-fil-A before. And I was there for his first Chick-fil-A experience. That was something.
He saw the light. I don't know what it is. Like, it's just so good.
There's got to be crack in it.
Okay, so back to Graston.
All right.
Where does that sit in your treatment? Pre-adjustment, post-adjustment? How does it sit with the rehab? Or if you don't have long with a patient, is it the kind of thing that you do often, or is it kind of the thing you'll just pull out if when needed, or if you had more time? Like, what's the kind of like clinical rationale behind the usage?
It kind of organized a lot of my, like all the other manual therapies I do, like cupping and like myofascial release. It kind of organized them. Maybe I'm doing the protocol without the tools. It's something, if I bring the tools like once in a while, I think now I'm confident enough with my hand strength where I kind of walked away from the tools. But if I'm doing like, I use it a lot for extremities more,
yep.
Not like big muscles. I would rather use my hands or like my elbow for myofascial release. But the courses did help me organize my thought process of like, okay, so how do I bring them from like manual therapy to rehab, and like what movements do I want them in while I do like the Graston. Graston is very big. It's very strict on like you're going from this movement to like this other posture, put more pressure on those, more weight on that tissue, and you kind of just like work on it while increasing the tension and the load on the muscle or tendon, and you just kind of progress upwards. And at some point, you're not going to be scraping on them where they're like squatting with a barbell. Yeah. So like at some point, the scraping stops, and like I'll start getting more into movement. I'll bring out more bands, more kettlebells, just whatever I have around.
Yep.
I obviously, like, when I work at the gym, I can bring up a lot of I like working with kettlebells. Just have them move around a little bit. But yeah, like I bring them up what the Graston tools, the actual ones, I'll bring them up once in a while, or some days, like long days where like my hands getting tired, I'll start bringing them out.
Yeah.
Do the same things, but just using the tools.
Yeah. And so, and in terms of adjusting or the spinal manipulation part of your treatment, is that kind of the bread and butter first thing you do, main thing you do? Like, what would you say about that?
Adjusting?
Yeah. Adjusting.
It's a lot of what I do.
Mm.
It's just not the only thing I do. Very rarely do I like not adjust somebody. Sometimes that's what they're coming for. If it's a gym or like my time, like I'm a little bit, I'll hold out. And like if I'm in an office where they're going to charge an insurance company for an adjustment and I know they're going to do it, I have to adjust. If I'm working in the gym I'm working at, or like a home visit or something, I'll hold up. I maybe do some myofascial release everywhere. Like I'm treating a neck, I'll do some myofascial release, stretch them out for the low back, and then but just focus upper thoracic, neck. Maybe if like they have a shoulder issue, I'll address that. But yeah, adjusting is it's something big I do. It's just not the only thing I do.
Yeah. And so where does the rehab fit into your practice? And when I mean rehab,
it's like,
sorry, I mean like exercise-based rehab. So like you're talking about the bands, the kettlebells, loading people into specific movements. Is that kind of the end goal? Or is that
yes.
like, because obviously some patients will get better. They would like, if they get better, they would
just adjusting.
Yeah. So is it kind of like the end goal of when you're trying to like get somebody through a progression, you know, you're going to have your adjustings, your bread and butter, you've got your other interventions, you know, myofascial release,
and just slowly start loading, and it just depends on the patient. Some patients that might be visit 2, some patients that might be visit 10.
Yep.
It just depends on how they're progressing, what their goals are. Especially at the gym, I want to introduce that as soon as possible.
Yeah.
Other practices, I'm limited on time, so like I got to leave it at that. And maybe we'll talk about. I'll prescribe some exercises so they can do at home. I'll walk through them once, and then every time I see them afterwards, I'll be like, "How are you doing the exercises? Any questions?" And just go through that. Not doing the rehab in the office, but kind of like send homework to the patient and just keep drilling that. Eventually that's what's going to get them over the hump. I like to tell patients that I can push your spine, I can adjust, I can massage all the muscles, but if I don't make that area like stronger than it was, I'm just setting you up for like this might happen again, or like I don't want the patient to depend on me.
Yeah, totally.
So I want them to have the tools to work on themselves at home. And if the things come back and it feels different, then come back, they'll reassess, get you some other things, and then we'll take it step by step.
Yeah. Yeah, it's like ultimately you have to get to the root issue. Sometimes modulating pain with an intervention will work only because the modulation of the pain lasts long enough for the person just to get better, like natural history of disease type thing, right? Like if they've just sprained a facet joint or whatever, if they've just pulled a muscle or whatever, and you're able to kind of stimulate the area, add some blood flow, some movement, modulate some pain through an adjustment or through other means, depending on your profession or the professional. That's cool. They may walk away, but they're likely going to repeat that poor movement pattern again and again and again and again. And what we kind of see, obviously, is people will, learn, or like I say, not learn how to move, and then they will repeat that thousands of times, right? So we have like these stress strain reversals and loads being migrated through tissue systems that don't have the capacity to handle it, and then they come to someone and you can't just crack it away all the time. And obviously you two understand that, but there are obviously professionals out there that will just do that, and then if they can't get them better past that, they kind of just like, well, just refer you on. The cool thing I love about what you're saying is You've got your techniques, you've got your interventions, but it's like ultimately you've got this progression or this pathway into loading and building that person's capacity so that when they go home and the next week they have to go pick up their child and asymmetrically load the spine because their child's jumping on them in an awkward way, maybe the capacity is a little larger and it can handle the migration of those forces prior to what they were before because you've given them the exercises or you've given them strategies on how to move.
So I think a lot of people just hear like, oh, you got to load your patients, and their minds just go like, oh, a lot of weights, a lot of like, and that's not really the thing. Like to a 65-year-old lady, loading the patient might be just standing up.
Totally. Yeah.
Might be just like have them stand up from the table, sit up and down. That's enough loading for that patient. And at least here, like when I tell patients, when I tell doctors here, hey, I do a lot of rehab. I want to like whatever eventually get to start loading tissues. Then like they'll tell me like we don't have workout equipment here. We don't have weights. Like I don't need that. At least to some degree, I don't need it.
Yeah.
And Puerto Rico has like a very old population, so like having to like learn to load your patients with minimal equipment, it's not hard. You're going to have a lot of patients you can load just by having them move around a little bit, stand up, and a 5-pound kettlebell. Yeah. That's more than enough for, at least here in Puerto Rico, that's more than enough for like 30% of the population.
Exactly. You don't, I like that because, especially with me being a powerlifter in the past, working with other professionals on a patient, and I've had the other professional be like, don't get them powerlifting. I'm like, whoa. Progressioning through into load, into proficient ranges of motion, it's not powerlift. Just because I've been a powerlifter in my life doesn't mean I'm going to get that person always. Like I'm not going to get them powerlifting unless that's a goal they want and that's a progression we'll get to. But it's just an assumption, and you kind of touched on it. You say to people, I'm going to load them, and they're thinking like 50 kg kettlebells, like full on this and that. It's case by case, right? Like exactly what you're saying. It's all contextual because for an older person, just teaching them how to move properly is going to load the proper structures that weren't being loaded before. Thus, they're going to get stronger in the right positions and they're going to be able to move better, right? Because before they were I mean, it's easy to use the back as an example, right? Because we know when people bend over, they slump, they twist, they round, and we know that what is associated with lumbar flexion is the movement of forces onto the passive tissues. So if you teach someone to move about the hips, actually move in a coordinated way, this is not necessarily saying they have a weak core. This is not necessarily saying they have weak glutes, because that's overstated. That's misinterpreted research. And they're just buzzwords that I can't stand. It's about coordination. It's about the movement of the system, teaching the person a skill, right? So the strength is a skill. When you get someone moving that way with no load, they come back and they're like, yeah, like I'm like I can feel my glutes for the first time in 20 years, or like it can be anything, right? It can be like, yeah, I can feel like this muscle on the back of my scapula. I can feel like my rhomboid. They don't know the muscle, or like I can feel my trap or whatever. It's like, oh, interesting. Like, because before there was along the way, there was some type of movement dysfunction or deficiency. I know a lot of people don't like to use like dysfunction or like those words because they can be quite strong with patients, but whatever you want to say, however you want to word it, beyond just those passive interventions, I feel like all healthcare professionals have a duty to be able to progress people into that, and I just don't think enough people are. I just don't see
it shows that they are, and they don't know, because when people think about rehab and load and progressing someone through rehab, they automatically assume you need heavy weights. Heavy weights are great if that's the end goal for the patient. Most people, it's not. They just want to be able to do whatever it is that they can't do. Maybe they want to get on the floor and play with their grandkid. Maybe they want to be able to walk their dog. Maybe they just want to throw a football or something like that.
Exactly.
And so
right.
you're going to give them exercises, and you're going to stop. Like, they're going to peak at some point, and that's okay. But maybe they peak and they're like, wait, I want to do more. And then you've shown them that there's even more they can do afterwards.
Yeah, because they feel safer. They begin, their
Yeah.
movements more coordinated. They have greater skill and they have greater strength. They feel better. They don't have to get out of bed scared that they're going to catch their lower back or get in and out of the car worried they're going to hurt themselves, or get off the toilet worried they're going to hurt themselves. You give them an inch and they want the mile. They want the second mile. They want the third mile. Like, they want more, because you're not just, and I think you touched on this before, you're trying to teach them not to need you. That's the beauty of our job.
Mhm.
And that's just really lost on so many practitioners that are kind of just rack and crack, taking their, clipping the ticket, taking the paycheck, and the patients are just rotating in and back and not really getting better. And that's why, like, when I talk to chiropractors, and it'll be interesting to hear your thoughts on this, like, how many sessions with a patient do you see them until you either have them better or refer them on? Because some people will just see people forever. And I should add a caveat. I'm not talking about when you've communicated with the patient and they understand they're coming in to receive like a wellness type thing. I understand that's different. And I know, like, Stephen does that and certain people do that. As long as you're communicating, it's completely ethical. I'm okay with it. What I'm not okay with is when you're just literally, you've gotten somebody addicted to you, like you're crack, because you're cracking them. You know what I mean?
Like, I like to tell patients, like, hey, I don't want you to substitute your pain meds for me. Switching like a dependence for another thing, even if it's me, hey, like, financially that's great for me, I guess. But for them, it's, you're still depending on something.
Yeah.
You still have to, like, come in once, twice, 3 times a week because you want to get cracked.
It's better for their liver. But it's better for their liver, but like, it's not better for the structures of the back that are just gonna become more weak.
To answer your question, I usually start with a 6 or 10 visit trial of care. If around those 6, and like between those, if I see I'm not improving, or like I'll reassess, and I'm seeing like, hey, I'm not helping you, I'll either co-manage, send you to somebody to co-manage, or like stop care if I'm like making you worse. But around there, like, I try to, like, ideally, like, it depends on the injury, but between those 6-12 visits, I'll reassess, and then I'll make the decision if, like, stop treatment, refer out, co-manage. Here is, which is something I had to learn. Here in Puerto Rico, like in Texas, I could go like, hey, I work with this like pain management doctor. I'm send you a direct referral to that doctor, so they can go see that doctor. Here in Puerto Rico, I can't do that. I can only do like a referral for pain management. They'll pick the doctor.
Yep.
So sometimes it's hard. It's kind of hard to co-manage, because back in Texas, I can co-manage with people that play with chiropractors and like would kind of like know what I do. And here, it's like, hey, I might refer this patient out and I might not ever see them again, because this pain management doctor might tell them that I was making them worse when I send them to get evaluated and maybe get some medication so they can tolerate treatment better, or like not me doing like a little bit of rehab and then they get super sore and then can't work for 2 days. So here I can't do like direct referrals. I can't even do for like imaging. Like I'll just write an an X-ray referral, and they'll pick the place wherever they want, which in the States they can also do, but you can kind of like keep track of treatment when you co-manage like that.
Yep.
Here you kind of lose track of it. You can't lose track of a patient if you co-manage and they decide to go to a doctor you don't know or you've never spoken to. But so yeah, I do miss that. But
so in terms of a profession, chiropractic is recognized and regulated by your Ministry of Health.
Yes.
I just wanted to know what your favorite go-to adjustment is.
Like
ring, ding, ding, ding.
No, not that one. I like to do like that diversified like T1 adjustment.
Seated.
Or like seated or like supine. Sorry, prone. Seated or prone.
Really
like
a thumb move? Or?
I use my Pisiform,
Pisiform,
just like that
yeah.
that scissor move. That one I really like. I really like adjusting occiput and side posture, I guess, but I don't really have a favorite adjustment. On myself, I really like getting my occiput adjusted.
Nice. A good occiput does feel good, eh? And how do you adjust the occiput? Is it like an occipital lift? Or is it just like a traditional a Gonstead thrust? Like, what's your go-to?
Kind of like, yeah, I kind of like that Gonstead thrust.
Yeah.
I'll use that knife edge on the jaw and just slip it.
Yeah, nice.
Like, I don't really like playing favorites.
Hey, everyone's got a favorite. Come on. Well, hey, you got a few favorites. You have a few favorites.
Yeah, I got a couple. So I can't pick one.
Fair enough. And because obviously you were part of MPI Club at Life and whatnot.
I was for a while, yeah.
Yeah. So you've learned all their stuff and yeah, and those types of adjustments. And you guys did a Gonstead class at Life, eh?
Yeah.
Yeah. Like those, I find like those adjustments were always interesting. I have like a C2 that's a little bit anterior. It's nothing that would be picked up on him medically, like from any other doctor, but because we were like drawing lines in the lab when I was a student, we kind of picked up on it. And then one of my teachers freaked me out about it and I was like real worried about it. But anyway, I was just getting like, before we realized that it was anterior, I was getting like constantly slammed, like, because obviously C2 was always lighting up with like listings. So it's like an easy thing to do in a student clinic. It's like if I walk into the student clinic, first thing you're going to get is some C2 findings because of my C2. So I was getting
C2 on the right.
Yeah, always like, yeah, it was always just like, yeah, C2 right, C2 left. And it would never make sense, but like the mentors would sign it off, as long as they could thrust into my C2. But I was getting so many P to A thrusts, and even the Gonstead ones, like they were particularly bad because they were just P to Aing the C2 even further forward. And it was just exacerbating my symptoms. So I'd like leave clinic just with like massive headaches, migraine, like cervigenic headaches, and just feeling just like sick. And it took ages until they realized that we went through my chart. Like by the time we finally got into clinic, I went through my chart and I was looking at all the listings, which I'm sure everyone's done. That's the first thing you do, right? I don't know, maybe just me.
Mm-hmm.
And I'm just like, holy crap. Like it just dawned on me. I'm like, these mofos have just been like punching bro, they've just been lighting up my C2 P to A for like two or 3 years. I was just like, holy crap. And then
that's how I got into dry needling. Like I would get massive headaches.
Yeah.
And this doctor went like, I'm not going to adjust you. I'm just going to put some needles here. And I stood up from that table. And I'm like, holy hell, I have no headache. Like my headache went away. You didn't even adjust me. Whoa. I'm like, okay, this thing might work. So that's how I kind of, man, I was getting like headaches. I was going to student clinic and it would help, but like I would weekly get into like massive headaches.
Yeah.
And like started doing dry needling and it's like, hey, I don't have to get adjusted this week. I'm feeling kind of good. Wow. And that really helped me out.
Mm. And you're saying I think you were saying at some point that you don't dry needle where you are, but you did do it when you were in Texas.
I did do it when I was in Texas, and it's not in our scope here.
Yeah.
You can do acupuncture if you have a master's in Chinese medicine.
Mm-hmm.
But other than that, you can't even do acupuncture, even if you have the diploma or anything.
I mean, up to last year, it was complete, like dry needling acupuncture was completely unregulated in New Zealand. So in New Zealand, like we have osteochirophysio, they are regulated, but in terms of actual spinal manipulation, it's not regulated apart from the cervical. So you can't, unless you're a chiro or an osteo or a physio, you cannot adjust the cervical spine, but you can adjust everything else, right? Which is crazy. But dry needling was unregulated for the longest time. And I had friends, I had my wife coming home being like, my friend is struggling to breathe. She doesn't feel good. She's lightheaded. And I'm saying to her, but she asked her to ask me because I was a student at the time. And I'm like, okay, like go to hospital if you don't feel well. Don't ask me. But anyway, I was like, what has she done? And she's like, oh, she saw her chiropractor yesterday. And And I said, well, okay, what did she get done at the car? Because I'm thinking at this point, like, maybe she did something to the lung, PDA, thoracic thrust. No, the chiropractor didn't adjust her. He dry needled up on her back, and she had a pneumothorax. Went to hospital, pneumothorax. The needle went through her lung. Didn't know, and nothing went. Nothing. There was no disciplinary process or anything. Nothing actually happened because it was unregulated, and the dude was just putting needles in people. Probably did an online course or whatever, and it was a crazy story. I remember thinking at this time, I'm like, we can, like, you can just like put needles in people's necks, but you can't adjust people's necks. Like, it just seems so crazy.
I mean, that's kind of how it is in Texas. So I haven't done I didn't do a dry needling certification.
Yeah.
It was a big part of what they did where I did my internship.
Yeah.
So I didn't do it, like, I literally did 3 months of like dry needling courses every day.
Yeah. You just learn from being there, like hands on.
Yes. Yeah. Like, yeah, they allowed me to help out, like put needles, and I would see the doctors. In Texas, it's kind of like that. It's not. It's basically part of our scope.
Yeah.
Because if you do a dry needling course, basically it's 95% like the anatomy, where are we putting the needles, which we kind of take in chiropractic school, and then 5% needling technique. That's kind of what you learn.
Yeah,
so
like the 45-degree javelin.
Yeah. In Texas, it's basically you have all the information. Learn it, like learn how to like put the needles, and you should be good. The company asked me for a letter of like the doctor who trained me, so they cover their asses, which I would ask too. And then they allowed me to dry needle in the clinic.
Yeah, because you're right. Level of anatomy training was, when I did my cert was like really, really good. And even then I was questioning and asking questions like, okay, like if we're going lateral from the spine, like if we're moving lateral out around the scapular region, I was asking all the questions. I wanted to have a real good idea of how deep's too deep, you know, like obviously you do like the javelin technique, or you do the 45-degree, whatever, what size needle. And then like you get answers like, well, it depends on the person, right? Because everyone's going to have different levels of like fat and muscle. And like that always really worried me, because I was just like, I felt like I was, based on like the size of the person, I was just picking the size of the needle and then picking where to put it and stuff. It always kind of freaked me out being near the lung fields. I was just I always thought to myself, like, you're safe if you're doing like multifidus, or like whatever, not specifically multifidus, but if you're doing like any deep spine muscle, like and you're javeling like into it should be fine, right? Or if you're like if you're doing the trap and you're actually picking the trap up and removing it, that's fine. But anytime I had to like even thought about going, like, it always freaked me out. And then hearing stories about people having issues as well, I was like, man, now that it's regulated, I feel way more comfortable about it. I might go see someone someone in my city that has like I think it's a 4-year degree they have to do in acupuncture or dry needling. I think I might go see someone, because I get headaches all the time, and like very little helps it, you know. Soft tissue stuff's probably the best. Adjustments make it worse. But I haven't had dry needling on it, so might try that.
That really helped me out. So
yeah. Anyway, hey, a fantastic chat. I mean, I was able to get through like seriously most of my questions. I've heaps of really, really good content, lots of great conversation. And I mean, it is our pleasure to have you on. I definitely learned a lot. I really appreciate your thought process on how you practice. I really appreciate how you think about what you're doing and your systematic approach to things. I love talking to people that are like-minded. So it's always awesome when we have like someone awesome on, and it's just like good vibes and it's on that same wavelength. You know what I mean? Because we need more people like you, more people like Stephen in the world. And that's why a big part of why we do this podcast is to try to push some of that good information, high quality content. Hopefully people listening to this, you know, maybe have asked themselves a few more questions, challenged their thought process a little bit, and it's a net positive experience for people listening.
Thank you for hopping on with us.
Thank you for having me.
Is there anywhere you want to direct people if they want to check you out?
Instagram, like rafafonseca.bc.
Yep.
If they want to check me out, or my clinic space is momentum_SSR.
And what I'll do, I'll post your Instagram when I post these clips. I'll make sure to tag you as well, just in case people want to
Mhm.
get in touch, or even like listeners, they might want to ask you some questions, especially
Yeah.
around I think the communication and cultural competency part of the chat was really valuable, and we haven't had a chat. We haven't talked about or covered that on the podcast to that extent before, so I thought that was really cool. So if you're somebody that is graduating soon, or what we spoke about resonated with you, feel free to reach out to any of us. I'm sure.
Talking to students, so like, hey,
Absolutely.
we'll work something out. So reach out and we'll talk.
Awesome. Well, hey,
And like I
once
said,
again, thank you so much for your time. It's been our privilege, our pleasure to have you on the podcast. And hopefully we will, or not hopefully, we would love to have you on again. What we often do is
anytime
we often bring back people when we have like another person on. So like we do like 4 people, which is always fantastic. And then we get to kind of synthesize your kind of view on chiropractic and treatment with someone else. And usually those make for really, really fantastic episodes. So we'll keep you in mind for that. Hope we can get you back on. Otherwise, we'll stay in touch on social media, and all the best for your practice, all the best for your work and what you're doing. And we'll make sure we stay in touch.
Yeah. Thank you guys
awesome.
for having me.
And see you, Steve. Have a good one. All right. Cheers, guys.